Well, welcome to another edition of Fresh Air with Sanjay and Matt. We're again delighted to have Irene Sansano from all the way from Barcelona to
Mm.
come and join us and show us cases and teach us stuff. Welcome, Irene,
Hi.
and also the brains behind the operation, which is Matt Cicchini. Matt, my colleague and friend from Canada. I guess Matt, if you're because you're the brains of the operation, that makes me the looks of the operation.
Yeah.
All right, Matt. Thank you for doing this. It's so great that you're putting it together. I can't tell you how grateful I am
Yeah.
that you're creating all this wonderful content
Mm.
and putting in your time to do this.
Yeah.
So welcome and take it away.
Thanks, Sanjay, and thanks, Randy, for joining us. And hopefully, there'll be some classic cases this time. There's no weird zebras. These are just kind of more bread and butter, which I think is really what Sanjay likes to see sometimes is these more classic cases. And so this is a surgical wedge biopsy that we have here. And I guess the first thing that I notice at low power is there's really this localized abnormality here off to one side here, whereas a lot of the rest of the lung looks relatively normal and uninvolved. And then the other thing I noticed at this low power is that the architecture is relatively preserved, where we were not seeing big changes, like looking like a fibrotic lung disease. Um, and then, so I kind of go into a little bit higher power here. Sorry about that. And then I think this case is a really nice example of all of these plugs of fibroblasts within these alveolar spaces. And you can really see them kind of having this really serpentine look as they kind of spread between different air spaces each of the case. So I think this is a really nice example of organizing pneumonia in these cases. Um, I guess the question for the group, in these cases, do you guys always do bug stains when you have organizing pneumonia like this, or what other workup do you do in these?
Irene, do you want to take that? Do you do bug stains in these organizing pneumonia cases?
I used to do, I think in the past, silver, but I don't do this anymore because and I never find unless there is necrosis
Yeah.
or something like that. I never find anything interesting.
Matt, how about you? Do you, so let me just put the question, like a specific question to you like that, okay? So pure OP,
Yeah.
right? And nothing else. So there's, it's just a garden variety OP, no granulomas, no
Yeah.
necrosis. Um, and then you do your AFB and GMS. How often have you had a hit?
Like probably zero.
Yeah,
I,
mine too. Mine has been zero too.
I still do it though.
Yeah.
And maybe that's just a training thing, but whenever I see organizing pneumonia, I always throw a GMS and a
Yeah.
ZN on it,
Mhm.
um, or a
So
ZN.
paradoxically, the same thing goes for non-necrotizing granulomas, like in
Yeah,
sarcoid.
yeah.
Those granulomas, I've been staining those for like 17 years. Nothing, nothing has ever showed up in any of those cases.
But the one time you don't, though, there'll be something there that you
Yeah,
you
yeah.
missed, right?
But that's
Um,
what we are afraid of as pathologists, right? That the low incidence event will bite us one day
yeah,
and we'll miss something.
yeah. But you're absolutely right, though. The yield of this is really low. The other thing I always do is in these is I always polarize it just to make sure there's no foreign material. But that's a low yield thing as well. And most of the aspirated material actually doesn't polarize. It's really just pill fillers and things like that will polarize, whereas a lot of more food particles often are non-polarizable, right? But I
Yeah.
always look for features of aspiration as well. Um,
Yeah. Let's ask Irene. Irene, so in an OP case like this, what kind of etiology have you ever found as a pathologist? Like as a pathologist, have you ever been able to tell what the OP is because of from histologic findings?
When there is a tumor next to it,
Okay, when there's something obvious, right?
or aspiration.
Aspiration, yeah. Hmm.
But normally, what the most common situation is that you check the history and there is a pneumonia a month ago or
Yes,
some weeks ago.
but that's not you as a pathologist figuring out
No.
what the etiology is, right? No.
No.
Matt, can I ask you like how? So, what are the settings in which you have found an etiology for the OP?
I think it would be a similar scenario, right? Aspiration. I've seen some cases in after treatment. So I've seen a few cases of. We have a program here where there's a study where they did stereotactic ablative radiation, so like therapeutic radiation, and then did wedge biopsies after it. It was published in a study, and to look at the response. In a lot of the cases, there was some organizing pneumonia in there as well. So as a treatment response to radiation, I've seen it. But in that case, it wasn't a big mystery either, right? Because
Right.
it came
Right.
labeled as that. But
So again, you're basically making my point, right, Matt? I mean,
yeah,
essentially, um, this is not something where. So if you're, let's say you're a clinician and you're expecting, hey, the pathologist will give me the answer now. He'll
yeah,
tell me that there's OP, or she'll tell me it's OP, and she's going to tell me what the OP is caused by.
yeah,
Right? The answer is basically almost zero
yeah,
unless you find aspiration. And frankly, even with aspiration, you have some other clues that something is going on, right? You have a giant cell,
yeah, exactly.
occasional giant cell, maybe a granuloma, some bronchiolocentricity. But aspiration is really pretty much the top of the list.
Yeah.
For bugs, what's your experience, guys, for finding bugs in pure OP? Matt,
As I said, zero, I think is.
Irene, have you found bugs in pure OP?
I don't think so. I
Me
don't
neither.
think so.
I haven't done it either. So, it basically comes down to you can do the stains if you want to. I mean, it's certainly possible. Actually, I remember one case where somebody was, there was a very high index of suspicion for a mycobacterial infection from their end. And I did nothing, my usual practice. I looked at the HNE and it's OP and I called it OP.
Yeah.
And then somebody else got levels on the case, and as you went into the third or fourth level, granulomas came out on the fourth.
Okay.
Like, you still don't know what the etiology is, right? I mean, it's a granuloma. Now it's OP with granuloma instead of pure OP,
Yeah.
and you still don't know what it is. So unless you find I've never found an instance in which a bug was missed and then somebody else found it,
Yeah.
or some kind of histologically evident etiology was present. So it
Yeah.
almost, I think people don't know that widely. People think that you are going to tell them the etiology.
Yeah.
But not well. The clinicians expect you to.
Yes.
They make the biopsy. If they know what is going on, they don't do a biopsy. Then
Yes.
they do the biopsy expecting that you tell them. Then you say OP and they call and say, do you have any idea? Then you do the stains because you want to do something else. You want to be helpful, and you find nothing.
Yes.
The-
Which actually is a really nice segue to bring up the point of this cryptogenic label, cryptogenic OP. So Matt, you want to?
Yeah, so COP, yeah, so it's to me that's a clinical diagnosis, right? And so they need to exclude it other causes. So I never put that as my bottom line diagnosis as cryptogenic organizing pneumonia. I call it organizing pneumonia, and then it's up to them to sort of the cause of it, right? And if there's no cause, then it can be classified as cryptogenic organizing pneumonia.
Yeah, Irene, how do you ever say cryptogenic in your biopsy?
No, I never say cryptogenic, but I find another problem. I think that there are three things. We find OP as an incidental finding also, not that it's something happening to the patient. Maybe you find OP and you sign out OP, but it has to be correlated with an image of OP or by the fact that I see some fibroblastic plaques. I don't know if the patient needs corticosteroids or not. They have to bottom line this thing, and then if they find not an etiology, they can say cryptogenetic also. I see. There is the pathologic diagnosis. There is the syndrome or the clinical situation of an OP, and there is the situation of an OP that we don't know the cause, and this is the cryptogenetic OP.
Right.
Yeah.
Right.
And we all mess. We call the things maybe not lung pathologists, but I keep hearing like in sessions or so, the patient had cryptogenetic. No, the patient had a pneumonia, then he can cannot have a cryptogenetic. But we keep saying it badly, all
Yes.
the doctors. And
Yes. Matt, you wanted to say something?
I just wanted to highlight one, I think the important teaching point in this case, you know, we often see a lot of these foamy macrophages in these cases as well, right? And so I think some people will often say, oh, there's a lipoid pneumonia that's going on, and say that, oh, they must be aspirating. And I just wanted to highlight that this is a feature of organizing pneumonia. You get this obstruction, you get this endogenous accumulation of these foamy macrophages. And this is not really the appearance of an exogenous lipoid pneumonia. That's much more coarsely vacuolated, and they tend to accumulate in the interstitium as well. So I think that is also a potential pitfall, especially for more junior learners, I think.
Yeah. Foamy macrophages have zero specificity for anything,
Yeah.
especially of this kind.
Yeah.
Foamy macrophages of this kind.
what about the amount of inflammation that you see in the plaques? Does it tell you something? I mean, do you want, if you see a lot of polymorphonuclears or a lot of lymphocytes there, does it tell you something?
Matt, you want to take it?
I always look for eosinophils, and we'll comment on eosinophils if they're present. If there's a lot of neutrophils, it might raise an infectious etiology, but other than that, I don't really comment on it too much. I don't know what you think, Sanjay.
Yeah, the question is a good one. Like what would make this different than garden variety OP? Yeah. And certainly there are lots of flavors, right? You'll get cases where there's an acute bronchopneumonia also. Here and there's neutrophils in the air spaces. And you can call those acute and organizing bronchopneumonia. But then is that really any different than organizing pneumonia? Maybe you've caught it in a slightly earlier phase, in a slightly acute phase. But it's the same, the implication is the same, right? It's like you had a pneumonia before and now it's beginning to organize. Same thing with eosinophils. I really do think that eosinophils change the game a little bit, but they don't change the game a lot. I mean, whether you have OP with eosinophils or you have an eosinophilic pneumonia that's organizing, the implication is still the same. It's probably steroid responsive, right? You still have to look for etiologies clinically. And I've heard some people saying, well, the spectrum of etiologies changes a bit. Like if you had a lot of eosinophils, maybe you would be looking for parasite or fungus. But I mean, again, honestly, you almost never find a great etiology. I've seen drug, but drug you should be looking for with any unexplained inflammatory infiltrate, right? So I don't know. Although you can get many flavors with OP, I don't know if it changes anything concrete, at least in my opinion. Irene, what do you think?
The same. I have nothing to add.
Yeah. I think it's a great discussion. I just want to make one more point about this case, is that these plugs of fibroblasts, I sometimes see people call these fibroblastic foci, and while they are foci of fibroblasts, we reserve that term for when we're talking about interstitial lung disease and these fibroblasts within the interstitium. And so the most correct term for these are fibroblastic plugs or Masson bodies. Would be that for this. Just another teaching point.
Yeah, that's correct. Irene wants to say something.
That's why I called it. In Spanish, it's difficult. You have the fibroblastic plaques and the fibroblastic foci, but we say I use Masson bodies for the plaques and focus fibroblasticus for the fibroblastic foci. Yeah. I would like to ask you also about, you said about if it's fibrin, no? Have you heard about this?
AFOP?
Acute fibrinolysis and organizing pneumonia. I think it's an earlier stage of this. But have you seen this evolve? This fibroblastic foci, these fibroblastic plaques collagenized? Have you seen this?
Yeah, I have. And like in the cicatricial variant of organizing pneumonia,
or maybe if you have a pneumonia and you take the biopsy some months later, it doesn't mean that it's going to be. But I see it sometimes like more collagenized, and I don't think that this is so talked or so said or so known.
Mm-hmm. Yes, that's true. There's a paper from Dr. Yusem about that cicatricial organizing pneumonia thing. But I think it's just describing exactly what you said, Irene. Like it just turns a little bit more collagenous with time.
And I guess that as organizing pneumonia goes well, most of the times you don't have an interstitial disease picture. But if this is too big to be reabsorbed, or maybe it goes like a scar, maybe
Yes.
these are the fibrosing ovaries.
Yes, yes. I think that's what happens. It just.
But collagenizing, I think, is the fate of all these fibroblasts. They collagenize and disappear, try to disappear like scars in skin.
Yes.
Yeah. I've also seen some cases where they've actually ossified as well, where you have like very, very prominent ossification after it.
Dendriform.
Yeah.
Yeah. I think, from the clinical point of view, I think pathologists, especially lung pathologists, I think we are all on the same page. This is another thing where we are all on the same page about this. We all understand what OP means and how it evolves, and what the implication is. I think from the clinical point of view, because they don't really see this picture, they don't see the microscopic, they don't really get it. They think that there has to be an etiology. Some of them have an etiology, and others will be labeled COP. It's a little cruder understanding of what this thing is.
And the fact that we use the same words, they are using all the time OP for a radiologic view, and it happens with interstitium all the time. They say cryptogenetic organizing OP, and we are maybe not seeing it's tough. Interstitium is tough.
Yeah. The other thing is I always correlate with the radiology, especially on small biopsies. And so if they're seeing a solid mass on imaging and on a small biopsy, all I have is organizing pneumonia, I'll make a comment that, this might not be reflective of the underlying process. And you can be perilesional, right? Because you wouldn't expect OP to cause a solid nodule. On imaging, it would be more of a ground glass.
Let me say, Matt, that I have seen that sometimes. Like I've seen solitary nodules sometimes. Yeah, like a solitary ground glass or a solitary consolidation.
But not a solid nodule, like a solid mass.
Not a well-defined nodule. Yeah, not the kind of nodule that you would expect to see in a cancer, for example. Not a really solid nodule. That's very unusual.
Like if the radiology was describing a spiculated nodule, they're very suspicious for cancer, and this is what I saw, this picture of organizing pneumonia. To me, that would be a bit of a disconnect.
Yes, that's true.
Yeah,
that is true.
Here we have, it's a cryobiopsy. I don't want to tell much before showing. I'm going to show it to you first, and then we can talk about the history. Okay?
Okay.
Then we have the classic kidney here.
Oh, yeah. I was wondering what that was.
Where is the kidney here? And we have the 5 pieces, or maybe here there is a little piece, 6 pieces. Okay, I'm going to show the pieces. This one is not very informative. It's a piece of bronchi. This one is a piece of bronchi with normal interstitium.
Yeah.
Without nothing on it.
Yeah.
Another one. Here next to this vessel, I presume that there is the bronchi hidden here somewhere, well, badly cut. Here is the epithelia. And we start seeing these things. Here again.
Hard to do much with that.
It's not a. I see what you mean, because I don't have a good piece of interstitium.
Yeah, you don't have a good piece of anything, right? Like no. in terms of abnormality.
Here.
Yeah.
And that's why I cut many times the blocks to see if I can see a better.
So is that pleura?
Sorry, no, I don't think
up so. There, or no? Is that interlobular septum right at the top of the?
No, I don't think so. I think
no?
It's. Okay. Let's see. Sorry.
Yeah, that at the top of that piece. What is that? Is that a blood vessel?
I thought it was a bronchus.
Yeah. Okay.
Without the epithelia.
Yeah.
No, because I have the anthracosis here, and so then again this. Sorry. And this is my best piece. In the other card, we saw here the vessel and the idea and the bronchi. And here we see again the same inflammation and this. What would you say about this cryobiopsy? Nothing?
Not much.
Matt,
do you want to take it? What would you say about it?
Yeah, I'm.
How would you sign it out?
I think I'd be descriptive, but is that fibrin in the air spaces, or what's that pink stuff
What's
there?
that? What's that pink stuff?
Yeah,
that is wavy and.
It looks more collagenous than fibrin, but
the shape is weird.
It is, yeah. It's not really conforming to the air spaces. It seems, whether that's just really old OP.
That's why I choose. That's my idea.
Yeah, is that this is more kind of like the aged OP or cicatricial?
Yes, I that's what I meant. This is a very old OP. I don't want to call it OP, but I think it's a very old OP. I think that from the shape, from the shape it takes, I think our Mason bodies here. You see one ossified, one.
Yeah.
And for the shape that, and I'll tell you the story. It's a 58 years old man that works in works with metal, like drilling, or I don't know, he works with that things. And he had a pneumonia in January, and this biopsy is taken like a year later. And after the pneumonia, they saw basal reticulation. Then they were wondering if the patient had a hypersensitivity pneumonia or giant cell pneumonia, or a collagen vascular disease. But the study is negative. The blood tests they got were negative, and that's the biopsy I got. Then does it change your mind at all, or
no? At least for me, this is just so minimal. The changes. All the others are normal, right? We all agree. All the other pieces are normal. And then this piece, there's some inflammation, maybe there's some fibrosis, but it's so minimal that I don't know what to make of it. Maybe I'm too strict in my threshold.
I did that. I said I was descriptive. I said I saw some inflammation, but around the airway, I saw no giant cells. I saw no distortion, and I said I saw this collagenous that I thought was cicatricial OP or evolved OP.
Yeah.
Nice.
Yeah, this could be anything. I mean, let's say somebody told you this patient is a 48-year-old woman with severe rheumatoid arthritis, seropositive, right? The lung is shows classic radiology for rheumatoid arthritis lung. Would you say that this is not consistent? It could be, right?
Well, the rheumatoid arthritis also can have OP.
Yeah, exactly. Yeah. So, I mean, yeah. I guess the main question is whether this is enough to call OP or not.
Yes, that's. I wanted to know your opinion on if this could be OP or not. I emphasize that there are no acute, there are no Mason bodies.
Yes.
It's no need. It's an old thing. It's not if it's OP at all, it's an old thing.
Yes. Certainly, the interstitium is abnormal here. I mean, in this field, no question about it. There's interstitial fibrosis.
And this is not SRAF.
Yeah.
It's not SRAF. It's wavy and it's tendinous.
Yes.
And I have the impression of having seen this sometimes coexisting with Mason bodies. Some Mason bodies partially collagenized like that.
I see.
But it's my crazy idea about how OP evolves.
Yeah.
I think I agree with you. I think that I have seen it incorporated into the wall as well, like that, and I think it's a bit of a pitfall for calling it NSIP, right? But this
Yeah.
is way too patchy for.
Let me show you this other, because I think it's another, there is another example here. Here, it is, this is more fresh.
Yeah,
Yeah.
like that one.
But the things happening. Like here, I have
Mm.
Mason bodies, but or it is not this one.
Yeah.
This one? Sorry. No, sorry.
Yeah. I think here it's just you have a better case to make that really is OP. Yeah, like here.
Here, but you have the real Mason body
Oh,
here,
nice,
and the other one is a bit the same, isn't it?
Yeah.
No.
So my question would be, Irene, how can we be sure that that is not a pre-existing interstitial fibrosis and the OP is on top of that? How can we be sure that the OP is turning into that kind of collagenization? It's impossible.
No idea. No how.
Yeah.
I mean, I would like to, if there, I would like to see the fibroelastic foci or the honeycombing or something more. This, I think this fibrosis is very, this with this color is very chewing gum color, or I don't know, it's very new, this collagenous. It's not just like the fibrosis in IPF, but it's something that I'm just thinking about while I see, now that we are seeing so many biopsies of pneumonias that we were not seeing before. That's something I'm just thinking.
It's a good point. It really brings up this whole OP turning into something cicatricial idea.
That's great. The many faces of organizing pneumonia.
Yes.
Many faces.
And we haven't even got into the difficulty of telling OP from fibroblast foci, which is a completely different topic,
Yeah.
right? Maybe we should at some point.
Yeah, no, that's, and I think you could show, like, some cases I don't think you get perfect agreement on and I think it's hard, right, to say conclusively where those fibroblasts are.
I noticed that first in transplant biopsies, that these are because in interstitium, what you get the biopsies at some point. There is an image that doesn't disappear, and when you have the biopsy, you get this classic OP. But in transplant, maybe you have this biopsy 2 weeks after the transplant, and you see AFOP. That is something that we don't often see in interstitium. And then you take the biopsy 2 weeks later and you see the Mason bodies, and you take it a month later because they still have some questions, and you have this collagenized. And that's why I started thinking this is the same, just unexpected.
Yeah.
Different stages. Yeah. I've also noticed the same thing, Irene. And like the fibrin to plug to collagenous thing. I guess where I'm a little skeptical about that is I'm not always sure that it's the exact same area that was biopsied every time, because every time they go in at a separate time, are they biopsying the exact same focus or they're biopsying something else? So it's hard to just from the temporal thing to be sure that this went to that.
Mm-hmm.
I'm not always sure.
I agree, but what happens to the patient is the timing, and what is happening to the patient is the same. That's why I think this is what happened.
Yeah. All right. So guys, this is, kind of like a very near and dear case to my heart, because this is one of the COVID autopsy cases that we had published back in April. Actually, this was the first complete COVID autopsy ever published in the world literature, complete autopsies.
Mm-hmm.
And originally I thought this was just, the first one in the English literature, and somebody must have done it in China before April, but actually there aren't. And as far as I understand, that in the Chinese literature, that they don't even do complete autopsies there. In the vast majority of the Chinese, like what they've reported is postmortem biopsies.
Wow.
There are several papers on that. There's one on lobectomies, but they just don't do complete autopsies. I think that's the reason that they didn't report it. So as you can see here, they've taken, these are cases from my colleagues from Oklahoma, from the Chief Medical Examiner's Office. So Lisa Barton, Edina Stroberg, Eric Duval, they were my co-authors. And so this is a piece of bronchus, obviously. You've got a lung with two beautiful bronchi in there. So, see the difference from surgical lung biopsies?
Yeah.
Where in a surgical lung biopsy, because you're peripheral, you won't get a bronchus in the section.
No.
But at autopsy, you can section those central areas, right? So the autopsy is really the only place where you get a bronchus within lung tissue like that. Of course, there's a bronchus in almost every section. And then here you have a bronchiole with a artery, pulmonary artery branch. So you have a bronchovascular bundle. And just one thing I wanted to mention, just, for super lung pathology nerds, is that even at this magnification, you get a little sense, very, very subtle, that something is wrong here in this area.
Agree.
Very subtle. It's like the difference between that, which is relatively normal, and that, where something's going on. A little bit busy.
Is there something going on down here too?
Oh, yeah. Oh, I didn't know you could circle it from your side, Matt.
Yeah.
Oh, that's so amazing. Yeah. How do you do that? So you just go up to.
So if you go view options and annotate.
Mm-hmm.
No, sorry. It's in Zoom.
Oh man, that's amazing. Yeah. Okay, that's great. Yes, so you're right. Yeah, this is the one you were doing, right?
Yeah.
Okay, let me also do that. So
so it's in the Zoom options. So
so you have it and I don't?
No, you can do it too.
I can do it also.
Yeah.
Here.
There you go.
Oh wow, yeah.
Oh,
okay, maybe next time I'll learn how to do it. So now you're I was just moving the image so your circle would be on the bronchus. Okay, so you guys, you're on the same page with me, right? There are several abnormal areas at low magnification. So one thing I'd like to point out here is that although this is going to turn out to be DAD, diffuse alveolar damage, it's not that diffuse.
Yeah, I think it's a big misnomer.
Normal.
Yeah,
and some areas are very abnormal. So if you go into that one, now we are in that area of abnormality. And let's keep the bronchus here for reference. Let's keep it to the left.
Nice.
And this is what you have here on the. So show me again so I can annotate it for the audience, Matt. So go to tools.
No, it's in the Zoom toolbar. So
up there, yeah. And annotate.
Yeah.
And then just pick up a.
And then you can either go draw or arrow. Are you in the annotation toolbar?
Oh, let's do draw. Okay.
Then you should be able to draw.
So this, for example. Okay, this is so beautiful.
There you go.
Yet another thing you guys have taught me.
You can even do like arrows.
Oh, that's amazing. That is amazing. Okay, so for the audience, the thing that I'm circling here is diffuse alveolar damage. And just to give you some background, this is all available free full text in the American Journal of Clinical Pathology. It's Barton et al., American Journal of ClinPath. This was an elderly gentleman who had, I believe, a remote history of splenectomy, hypertension, but no other major predisposing causes, who suddenly got sick at home and then on the way to the hospital, basically had a cardiac arrest and died soon after in the hospital, never went on a ventilator, never had any kind of, right? So no oxygen, no ventilator, nothing, just pure, COVID. And was not known to have COVID, but when they swabbed the nasopharynx and the lungs, both were positive. So it was positive in the nasopharynx, positive in the lungs. And later on, we did another study that's also published called Best Rocha et al. Lab investigation. They did both immunohistochemistry and SISH at the Arcana labs in Arkansas. And it was positive for SARS-CoV-2 in the lung. So this is a well-documented SARS-CoV-2 positive case, no treatment at all. So everything that you're seeing here is pure virus. There's no treatment effect. And what I'm circling here, obviously, is hyaline membranes, guys, right?
Yeah.
Agreed. What else can we show in this picture? The one thing I'd like to point out is the blood vessels are pristine. And again, I think people there's such a divide here among pathologists. Some people feel that every case of COVID has to have thrombi in it, has to have diffuse pulmonary microthrombi, and that explains the shunt and the odd symptoms and this and that. I agree with all of that theory. I agree with the theory, But let me just circle the blood vessel for you before we go to. Okay, so I completely agree with the theory, but in practice, this blood vessel is normal.
Yeah.
There's no thrombus in here.
And the other thing is you can see that as part of a DAD picture, right? You know,
Yeah,
fibrin thrombi are well characterized
exactly
in
right.
any cause. And so to me, the challenge has always been that's a normal part of DAD. And if there is, it's just a variable. It's more prevalent in this disease etiology than others potentially, but this can occur in any underlying cause of DAD.
Exactly right. I'm totally with you there, Matt.
The idea is the mechanism. I mean, when you hurt the pneumocytes and the endothelium, there is an answer that it doesn't matter what starts the problem. They start segregating fluid, and what happens is DAD, no matter the etiology.
Yes, correct. Absolutely right, Irene. So I agree with both of you on that. Let's see what else we can see here. So should we talk a little bit about the interstitial infiltrate? Because then, that's also kind of an interesting thing. In viral pneumonias, classically for decades we have known that there is some kind of an interstitial pneumonia, right? Like an
Yeah.
interstitial inflammation. Actually, interstitial pneumonia is an odd term because that even DAD is an interstitial pneumonia in a
Yeah.
way. But what I'm saying here is that you can also get interstitial inflammation
Yeah.
like this and interstitial lymphocytosis. And even that to my eye, guys, it's not all that diffuse. It's like relatively patchy. Let's go back down. So, it's not the kind of interstitial inflammation you get in NSIP or hypersensitivity. It's very patchy interstitial inflammation. And then when people say, well, are you seeing evidence of the cytokine storm? Like, I don't know. What is evidence of the cytokine storm? Certainly, these inflammatory cells could be producing cytokines. The cytokines could be causing DAD, right? But what is evidence of the cytokine storm? I don't see that much of a.
I am imagining the microscope shaking like in the
Microscope is shaking and the tissue is. I don't get that. Oh, one interesting thing I did see in these cases, which I don't know if that's just an artifact, is these megakaryocytes.
Oh.
I've seen some of them being very prominent, but I don't know how specific that is.
Yeah.
I bet if you see 20 autopsies, 10 of them will have prominent megakaryocytes. But
Yeah.
people have mentioned that in the literature, if you see, that you can get prominent megakaryocytes in these COVID autopsies.
The other thing
Um,
I noticed in this case is the interstitium is really not that expanded. So maybe that's just because it's a fairly early on in the DAD
Correct.
process. It's really
That's
just
correct.
more in that kind of acute exudative phase.
Yes.
There's really no organization. There's really no proliferation of fibroblasts or anything.
Yes, that's exactly right. And that pretty much is true wherever you go into these abnormal areas, that it's the alveolar septa are almost normal, but it's a
Yeah.
very early stage.
Congestive a little bit.
It is congested. Yeah. Actually, people have also brought up congestion,
Mhm.
where there's no DAD, no nothing, no OP, no DAD, no bronchopneumonia, no thrombi. People have reported congestion as a feature of.
I think all the all the necropsies have congestion.
Yes, every autopsy has congestion in it. So, again, you have to think of, you can certainly report everything you see, but does it mean anything? I mean, what does that even mean? Every autopsy has some degree of congestion. So I'm very skeptical about that.
Yeah, you
I
need a control group of that had DAD who died, who had an autopsy that were non-COVID related, right?
yes, and people have also shown that if you compare this with control groups like viral pneumonias of other types, the findings are essentially identical. If you compare it with SARS or H1N1, it's essentially the same pathology. It's diffuse alveolar damage, interstitial inflammation, some degree of thrombosis, and also airway inflammation. Can I just show you guys the airway inflammation part and
Yeah, that'd be great.
ask you what you think about that? So this is what the airway looks like in this case.
Just a second, going back to the megakaryocytes, I remember something about that were more prevalent in sepsis or something. I remember having read that were that are incidental findings but are more prevalent in sepsis cases of any etiology.
Yeah, it could be. It could be, Rene. I'm just not, yeah, it certainly could be. And which means then again that it's not specific to a certain etiology, right? It could be, since sepsis can be from a variety of different bugs, usually bacterial, right? I mean, most of those cases are bacterial. It certainly would not be specific for a viral pneumonia, and certainly would not be specific for COVID to have lots of megakaryocytes in the thing. But people, I have even seen papers that have tried to correlate the presence of megakaryocytes to some sort of a thrombotic tendency. You know, there's all sorts of hypotheses that have been put out there about why COVID behaves the way it does based on the pathology, which I think all of them are a bit uh, difficult to believe. They're difficult to believe.
Bending statistics to make it work to say what you want to say, it's an art.
Yes, I know. You can pretty much use statistics to make anything look like anything, which we know well from the lung cancer world. One thing I wanted to point out here is I thought here that the mucosa is really edematous
Agree.
in this particular case.
Especially at low power, you can really notice it.
Yes, low power is the best. See how kind of juicy it is, the mucosa? And it is pretty inflamed. Although people have also mentioned that maybe intubation itself causes some degree of mucosal edema, and maybe that's this patient probably was intubated, not ventilated, but might have been intubated, on the way to the hospital.
Yeah.
I don't know how far down the bronchi that kind of edema goes, but it's possible. But also has inflammation. Do you guys agree? Like a little bit of bronchial mucosal inflammation.
But maybe bronchi have this inflammation, or
normally.
The little bit of basement membrane prominence there, right?
Oh, yes. Yes, a little bit of a basement membrane thickening.
But that's really not that specific.
None of it is specific. In fact, you can argue that even DAD is not specific at all.
No.
So nothing here is specific, right? But it certainly shows you what here could have killed this patient. I mean, the DAD for sure is a good cause of death. I mean, you have, if not etiologically good cause, but definitely a good pattern that would cause death. In other words, this explains why this patient might have died of a pulmonary illness.
But histologically, this is really no different than the cases we saw last year with the vaping associated lung injury, right? In your autopsy series that had DAD, right? So I think it just highlights once again that the lung has a limited way in which it can respond to injury, right? Whatever the insult is, the lung responds in a very similar way, whether it's viral or whether it's an inhaled toxin. You can get organized pneumonia or DAD, and they histologically look all the same to us under the microscope.
That's correct. Irene, anything to add to that?
No, just a comment. I have. Who does? Do you look at all the lungs in the necropsies in your own department, or?
We don't, Matt. I'll let you answer that. But in our department, we don't. Irene, there are autopsy pathologists who do their own interpretation.
Everybody sign out their own necropsies.
Correct. Yes. Correct.
Yeah, and that's how it's here as well. I don't do autopsies as part of my practice, but I'll consult on the lungs when there's specific pulmonary cases, whether they're trying to characterize interstitial lung disease or things like that.
Yeah, I think that is in general, is good practice to get lung pathologists involved in the lung part of the autopsies, because there are things that lung pathologists appreciate, which is, it's just a function of your training. I think it is good practice to.
And there are etiology. There are things that you only see in necropsies. We only would see in necropsies, and I like to look at it. I find that it's difficult to say if it's normal or not for general pathology or for other pathologists from other specialties. Maybe we are discussing if this is a thrombi or not.
Yes.
I have to say, I find autopsy lungs one of the most challenging specimen types with all the autolysis and the artifactual collapse that I find them incredibly challenging specimens to characterize and to work through. And I find they take me so long to really stare at and sort out what's artifact, what's real. And
Yes.
And I,
That's why I find, there's so many reports. If you go back to the literature on viral pneumonias and things, fatal viral pneumonias,
yeah,
there are so many reports of things that are clearly just artifactual.
yeah,
They say bronchial desquamation, denudation of the epithelium, hemorrhage, congestion. You're thinking, well, that's every autopsy is that.
yeah.
It's every autopsy from any case.
yeah.
It's just so frustrating to see people reporting artifactual things as pathology. I guess that's the nature of the game.
It is difficult to look at these specimens, and sometimes there are the necropsies are patients that have an interstitial disease, and they want to find out, and you have everything added on it because the interstitial disease didn't kill the patient. Then you have a pneumonia on top of something, and you want to see how say NSIP in that case.
Yes,
Yeah.
exactly. Impossible. Yeah. So I think that was it for this particular COVID case. The
Yeah.
other one, the bronchopneumonia, is a more complicated case.
Yeah.
But I think this is the one, this is really the most classic uh, pure COVID DAD case you will see. Just, has an um,
Did you perform immunohistochemistry in this case?
we did, yeah. So immunohistochemistry showed a CD3 positive T cell lymphocytosis and a little bit of both CD4 and CD8. And that's about all I did. And then when we later looked at the SARS-CoV-2, we found SARS-CoV-2 viral particles by in situ hybridization and immunohistochemistry in the lung,
In the
in
pneumocytes.
in the pneumocytes,
Cool.
but not in the kidney and other organs. So it was only in the lung.
Cool.
I've read also in scammers from the swabs something that they have found it also in these cells in the nasopharynx.
In the nasopharyngeal, yes, correct. That's exactly right. And I think that that paper from the CDC, the first one from Rosa Celis Martinez, also showed that by immunohistochemistry and IHC that they have viral particles in the nasopharyngeal mucosa. And interestingly, actually, what I find the most fascinating is they showed viral particles by immunohistochemistry in the hyaline membranes.
Oh, cool.
Inside the hyaline membrane. Yeah.
I was just going to ask that. Did the viral particles correlate with the areas of DAD, since in the DAD is a bit more patchy in this case?
In my case, I don't know, because the immunohistochemistry was not done at our institution. But yes, I do seem to recall that where the viral particles were was where the DAD was. I just don't know were there also viral particles where there was no DAD. That's I don't recall that. But that's a very good point. Certainly, the CDC paper seems to show that viral particles were in the hyaline membranes, which would mean they're at least in the DAD areas, right?
Yeah.
I'm just not sure if you also see them in the areas that don't have DAD.
Not in these bronchi that are so thickened. You didn't find it there?
I don't recall seeing it in the bronchi, but again, in the CDC paper, the bronchi also had. In the bronchial epithelial cells, they actually show it in the epithelial cells, positive immunohistochemistry.
I guess it makes sense it's in the hyaline membranes, because really the hyaline membranes are just kind of the result of this proteinaceous debris from the dying and injured pneumocytes, right?
Yes.
So if it's the virus is infecting the pneumocytes, it's probably makes sense that you'd see it in the hyaline membranes as well.
Yeah, I think it does make sense that they would be in there. It's like like if you died of smallpox and your body disintegrated, that the smallpox would be in there, in that debris, right? It's kind of like something like that. That's the concept behind that.
I guess so, yeah. Well, that's great.
Yeah. So that's basically the sum total of the histology in this case. And of course, as you know from the paper, the other one did not show DAD, but that was a different case. The patient had myotonic dystrophy, so that's a completely different story.
That's great. I think this is a great session. We highlighted some kind of classic features of acute lung injury in the spectrum that you can see, whether it's more fresh or more collagenous in Irene's case, and then DAD with a very timely example. Yeah, so I think this is great.